Hi, welcome to UWorld's FNP QBank Live Review Session Number 2. My name is LaQuisha. I am one of the family nurse practitioners on the medical content development team here at UWorld. During our last session, we reviewed the 4 competencies that you're going to see on your AANP exam and 4 of the 5 competencies that you'll see on your ANCC exam starting this September. Those were assessment, diagnosis, plan, and evaluation questions. If you'd like to go back and see that video, it's still there for your review. Today, however, we will be going over high-yield image-based dermatology questions. So all of our questions today are going to be diagnosis and plan. If you're sitting for your AANP exam, diagnosis questions are going to make up about 26% of that exam, while plan questions are going to be 25%. If you're sitting for the ANCC exam, diagnosis questions are going to be about 17%, and plan questions are going to be 19%. So about half of the AANP exam and about a quarter of the ANCC examinations. So speaking of the exam, test tip number 1. Ideally, you actually want to take your test as soon as possible after graduation. That way, all of your information is still fresh on your mind. So ideally, 30 to 60 days after you graduate. But you would actually want to start studying for that exam 4 to 6 months before you sit for your test. That's where the UWorld FNP QBank comes in handy, because not only can you have this platform to use starting day 1 of your FNP coursework to make sure that you are understanding your important concepts in real time, but you can also make sure you have this platform to use during that 4 to 6 month period to make sure that you're adequately prepared for your exam. So since we're going to be talking about study tips as well, at the end of this session, I'm going to actually go through the UWorld FNP QBank to show you how to utilize key study functions and features to ensure that you're maximizing your chance for success on each exam. So today, the flow of the session is going to be, we're going to go through our questions like we did last time, and then go through the rationales of why each question is correct versus why they are incorrect. And then at the end, I will show you how to use those key study functions. Sound good? Let's get started. So here's our first question, and this is our first high-yield image for derm. I'm gonna let you look at that for a second before we get down into the actual stem of the question. Okay. A 6-year-old girl presents with an itchy rash on her head. It began as a small area of scaling that has progressively enlarged with increasing pruritus over the past 3 weeks. No other family member has this rash. Physical examination shows erythema, scaling, and areas of alopecia on the scalp, as seen in the image above. Potassium hydroxide microscopy of skin scrapings and follicle specimens shows hyphae and spores. Which of the following is the most appropriate treatment? A, oral griseofulvin. B, topical clotrimazole. C, topical hydrocortisone. Or D, topical permethrin. Now I'll give you a second to review this to see if you can come up with the answer. And here is the image for reference. Now let's scroll down and give you a chance to look at those answer choices as well. The answer for this question is A, oral griseofulvin. Now, looking over at the explanation, we're going to review those UWorld philosophy for knowledge retention. So the first thing you're going to see is some sort of image, whether it be a chart, a graph, a photograph. Today we have an actual image. So Tinea Capitis is what we see in this photo. And on our labeled image, you see there is an area of alopecia and scaly erythematous patch in the center of this patient's scalp. Now, the second portion of UWorld's philosophy for knowledge retention is going to be these bolded keywords that are important for you to know in order to get the educational objective. So this child has Tinea Capitis, which is also known as ringworm. It's an infection of the scalp. It's a very common infection that is typically made, the clinical diagnosis is made based on the presence of an itchy, scaly, erythematous patch. Sometimes there's also patchy alopecia, which just occurs when the hairs break off at the scalp, leaving the appearance of black dots. It can be diagnosed with the potassium hydroxide, or KOH PrEP, and on the examination of the spores of the hair shaft. The only effective treatment is going to be a systemic antifungal, which typically is oral griseofulvin. Now let's go through and see why B, C, and D were incorrect. Typically, topical clotrimazole, which is a topical antifungal agent, is not going to be very effective just because it doesn't penetrate the hair shaft and is not going to actually eradicate the fungi. Choice C, topical hydrocortisone. If you remember last week, we had another tinea infection or fungal infection, and we always said that you never put a steroid on a tinea infection because it's actually going to make the infection worse due to the fact that it has immunosuppressant effects. And then choice D, topical permethrin is actually the drug of choice for head lice. But while it also presents with itching, like in this patient, it does not have, you will also see nits. And in this patient, you don't see those nits that are visible on the bottom of the hair shaft. So, and also this, the head lice is not actually going to show alopecia. So that's just an incorrect diagnosis and an incorrect treatment. So the third part of UWorld's philosophy for knowledge retention is the educational objective, that very short blurb, which is your takeaway point from each question. So for this one, Tinea Capitis is a common pediatric fungal infection that presents as an itchy, scaly, erythematous scalp rash with progression to area of alopecia. Systemic antifungal therapy is required to effectively penetrate the hair shaft and eradicate the fungi. So just so you know, this was an actual plan question, most appropriate treatment. I want to make sure that I make sure that's clear. So let's go on to our next question. A 7-year-old boy is brought to the office for follow-up of a flare of atopic dermatitis. 10 days ago, the patient was prescribed a medium potency topical corticosteroid for 2 eczematous, intensely pruritic plaques on the left leg. He has been applying the medication twice a day and have also applied topical emollients twice a day as maintenance therapy. Skin examination is shown in the exhibit, which I will show shortly. Which of the following is the best next step in management? A, add oral prednisone. B, add topical mupirocin. C, discontinue the emollients and observe. Or D, recommend wet wrap therapy with a high potency corticosteroid. Now let's take a look at the image in the exhibit. This is actually what you see on that patient. So I'll give you a chance to kind of examine the photo and see if you see any clues for how to treat it. Okay, let's go back to our stem. Now, since this is asking for the best next step in management, this is a plan question. I'll give you a few seconds to review it. The answer to this question is B, add topical mupirocin. So let's see if we can pull up this image again, just so you guys can take a look at it before we go through the explanation. Now we know that this patient had a flare-up of atopic dermatitis, which is also known as eczema. And a risk factor for that is, history of atopy, which is eczema, asthma, or allergic rhinitis in the family. Key features of the itchiness, the patchiness, It shows differently in infants versus children and adults, but he's using the actual therapy. But because this patient had an atopic dermatitis that was not actually being treated by or had a different super infection on top of that dermatitis and it wasn't going away, that's when you want to make sure that you're actually getting an improvement in that infection. His lack of improvement, in addition to those honey-crusted lesions, indicate a secondary infection, most likely impetigo. Staphylococcus aureus is a very common pathogen that causes infections because most people who have eczema are already colonized with that bacterium. Now, the classic impetigo is going to show up as a golden crusting in weeping and purulence that is seen in this patient. The treatment is going to be topical mupirocin for localized infection or oral antibiotics if it was widespread. So going through the other answer choices, A, adding oral prednisone. If this patient had a severe eczema flare, then sometimes a short course of oral prednisone is considered for treatment. However, this is a 7-year-old boy. So we typically do not prescribe steroids in young children because they have pretty bad systemic adverse effects. It'll stunt their growth, it can cause them to have weight gain and other things. Additionally, because this patient had those golden crusted lesions, it kind of suggests an infection, so not a refractory atopic dermatitis. Choice C, discontinue those emollients and observe. Well, sometimes if you have a patient who comes in with a atopic dermatitis flare due to like an irritant or an allergen in the emollient, like a fragrance or preservative, this would be a good answer choice. But again, those golden crusts make contact dermatitis very unlikely. So if you actually discontinue the emollients, it would make the eczema, the underlying eczema, much worse. And then D, recommend wet wrap therapy and a high potency corticosteroid. We normally use wet wrap therapies to cover skin treated with emollients or topical steroids to enhance the hydration and the absorption of that steroid medication. But because of the use of high potency corticosteroids, it's going to be avoided due to increased systemic absorption when you occlude it with that wet wrap. And moreover, that therapy is going to be reserved for widespread eczema, severe eczema flare-ups, and it's going to be contraindicated if there is a concurrent infection as well. So that makes that also the wrong answer. So the educational objective for this planned question is atopic dermatitis can lead to a secondary infection as a complication, which should be considered when standard therapy, e.g. those topical corticosteroids, are ineffective for a flare-up. Impetigo classically presents with honey, golden crust, weeping, or purulence, and treatment involves topical mupirocin or oral antibiotics. So let's move on to that next question. So this is going to be the image for our next stem. I'll give you a chance to review it for a second. Okay, let's scroll down. A 7-month-old girl is brought to the office due to a rash. The rash began 3 days ago on the girl's buttocks and has spread to her genitalia. The mother reports frequent diaper changes and trying new baby wipes with no improvement. A week ago, the child had a mild diarrheal illness that has since resolved. The rash is shown in the image above. A similar rash is present over the labia, but not over the inguinal folds or thigh creases. Which of the following is the most likely diagnosis for this patient? So this is a diagnosis question. A, impetigo. B, eczema. C, candidal dermatitis. Or D, contact dermatitis. So let's scroll back up to the image for just a second so you guys can kind of get a look at that before looking at the answers again. Now let's scroll back down to the stem and the answer choices. The answer to this is D, a contact dermatitis? So for this question, let's go through a breakdown of what they are looking at in the stem that will lead to this question. So the rash began 3 days ago on her buttocks and has spread to her genitalia. The mother reports frequent diaper changes, most likely due to the mild diarrheal illness, and trying new baby wipes with no improvement. And then a similar rash is present over the labia, but not over the inguinal folds or the thigh creases. So if we come over to the explanation, we have this chart for diaper dermatitis. There's contact versus candida. The most common cause is going to be contact dermatitis. It spares the creases and skin folds, and this is the treatment, which is a topical barrier ointment or paste. Candida, which is the second common cause, is going to be a beefy red rash that involves the skin folds and has satellite lesions. So let's take a look at the explanation. Irritant, or contact diaper dermatitis, can happen when you have prolonged exposure with water, friction, or prolonged contact with excretions such as diarrhea. You're going to see erythema in the diaper region that will spare those skin folds that are typically not exposed to whatever is contributing to the rash itself. So the appearance after a diarrheal episode is actually quite common. Diaper dermatitis is diagnosed clinically. That means management focuses on keeping the area dry. Measures include frequent diaper changes, avoiding excessively tight-fitting diapers, and then the application of a barrier cream. Gentle cleansing with soap and water or alcohol and fragrance-free wipes are also recommended. So let's review the incorrect answers. Choice A, impetigo. So we actually just had a question about impetigo, which can cause a bacterial superinfection that can occur in diaper dermatitis, but we don't see those honey-crusted lesions that we saw in the last image, so that makes this one an incorrect answer. Choice B, eczema, also in our last question. It's an itchy, erythematous, patchy skin eruption that normally presents in the flexural surfaces, cheeks, or trunks in infants. Since this patient's rash is localized to the diaper area, it makes that diagnosis also unlikely. And then choice C, the candidal dermatitis that we saw in our above chart. It normally presents with a beefy red plaque. You're going to have those tiny satellite lesions and involvement in those skin folds. But since we do not have that and this patient's rash spares the skin folds, that makes that answer choice also unlikely. So let's review our educational objective. Irritant diaper dermatitis presents with erythema that spares the skin folds. Management includes frequent diaper changes, avoidance of excessively tight-fitting diapers, exposure of the skin to air, and application of barrier creams. On to our next question. This is the image for that question, so let's take a second to review it before we go down to the stem. Okay. A 32-year-old man presents with a rash on his neck. The rash has been present for 6 months and is associated with mild pain and tenderness. The patient has tried several emollients, cleansers, and astringent products without relief. Examination findings are shown above. Which of the following is the most likely diagnosis? So this is also a diagnosis question. A, Acne vulgaris. B, Pseudofolliculitis Barbae. C, seborrheic dermatitis. Or D, Tinea Barbae. Let's go back up to the question. I think I can get them both on the screen so that you can see them at the same time. Now the answer for this question is B, Pseudofolliculitis Barbae. So as we see on the explanation side, this is going to be characterized by small papules that develop after shaving. So it's kind of right in that area where a man would be shaving to get all of that off of his neck. It is small, painful papules that are consistent with Pseudofolliculitis Barbae. It's often known as razor bumps or ingrown hairs. It's caused by the penetration of the hair shaft back into that skin which typically occurs in all ethnic groups, but is most prevalent in Black men due to the tightly curled facial hair that they have on their face. Shaving with multi-blade razors, which cut the hair below the skin surface and leave that kind of angled tip, will increase that risk of it curling back into the skin as well. This is also made by a clinical diagnosis. Some complications can include hyperpigmentation and secondary bacterial infection. Very rarely they may have keloids, but that is also something that's to be noted. So let's go through and see why the other answer choices are incorrect. A, acne vulgaris. Inflammatory acne is typically a small, inflamed, tender papule on the neck. However, it would also be seen on the face, chest, shoulders, and back. So let's actually take a look at this hyperlink so that we can kind of compare it to the pseudofolliculitis. Now, the mildly inflamed papules and pustules noted around her chin here are labeled, but you also see it involves the rest of the face as well. Doesn't quite look like, I don't know if I can move that out the way, doesn't quite look like this where there's no redness, no pustules, or any inflammation noted. Choice C, seborrheic dermatitis. It normally comes also with erythematous patches associated with greasy scales, which is going to most commonly affect the scalp, the ears, the eyebrows, and the nasolabial folds. We also have another image here. So as you can see, that scaling with the surrounded erythema there, that does not look or resemble like the image in our current question. And then choice D, Tinea Barbae. It can also present with papules in the beard area, but they are also erythematous, scaly, or pustular, and very itchy. Additionally, the lesions are going to occur in an annular pattern. So the educational objective for this question is that Pseudofolliculitis Barbae, or razor bumps, present with small, painful papules in the beard area. It's caused by the penetration of the hair shaft back into the skin, often due to shaving of tightly curled hair. Complications include hyperpigmentation, secondary bacterial infection, and keloid formation. Management is going to be discontinuation of shaving or using an alternative shaving technique. Okay, let's move on to the next question. This is going to be our image. You guys take a look at that for a second and we'll go down to the stem. Okay, a 67-year-old man is evaluated for a sore on his right cheek that now bleeds, oozes, and has been open for the last 3 weeks. The patient thinks that it has grown slowly over the past year. Physical examination shows a punched out 1.5 centimeter ulcer on the right cheek. Full thickness biopsy reveals basal cell carcinoma. Which of the following is the best next step in management? So this is a plan question. A, cryotherapy. B, Mohs surgery. C, radiation therapy. Or D, topical chemotherapy with 5-fluorouracil. Give you guys a few seconds to look back up at this question. And the answer to this question is B, the microsurgery procedure. So basal cell carcinoma, which we were told in the stem, is the most common form of skin cancer in the United States. It rarely metastasizes, but it may grow and invade that nearby tissue and structures. So here's a good image of the actual microsurgery procedure. You see this lesion similar to what we see on this side over here. Thin layer is removed, and the next layer is removed, and then finally the final layer is removed. So you see it goes very deep into the skin. So some possible features include persistent open sores that bleed, ooze, or crust, which is what we see in our patient in our stem. There can be a reddish patch or irritated area, which is known as superficial basal cell carcinoma. It can be a pearly or translucent nodule that's pink, red, or white, which is known as nodular basal cell carcinoma. It can be an elevated or rolled border with central ulceration, or a pale scar-like area with poorly defined borders. So the treatment for this is going to depend on the size, depth, and location of the cancer. The low-risk versions can be managed with standard surgical excision, but in contrast, you will use the Mohs micrographic surgery for high-risk basal cell carcinoma, such as on large or high-risk areas of the face. So the center of the face, your nose area, your lips, or on the eyelids, which is seen in this patient. So let's take a look at why the other answers are incorrect. A is cryotherapy. Now, cryotherapy is an inexpensive and effective treatment for many benign and premalignant cutaneous lesions, but we don't really use cryotherapy in malignant lesions like a basal cell carcinoma, and it's often restricted to low risk and very superficial disease, and that's only when better treatment methods aren't suitable to be used. C, radiation therapy. Radiation therapy is occasionally used to treat basal cell carcinoma in patients who are unable to undergo surgical excision, but that's not going to be the first line management in this type of carcinoma. And then choice D. Now, low risk superficial basal cell carcinoma may be managed with topical therapy using either the 5-fluorouracil or imiquimod. That is a tongue tie. These agents may also be used in field therapy for patients with multiple actinic keratoses, but they're still going to be less effective in nodular basal cell carcinoma and are not recommended. So the educational objective for this question, basal cell carcinoma has a low metastatic potential, but should be removed surgically to prevent local invasion. Mohs micrographic surgery, in which thin layers are removed and inspected microscopically to ensure clear margins, is used for high-risk lesions and in delicate or cosmetically sensitive areas. Now, here comes our last question of the day. This is the image that's going to be used for the stem, so take a look at it. And then let's go down. A 48-year-old woman comes to the office due to a lesion on her neck. The lesion has been present for the past 6 months and is slowly enlarging. Skin findings are shown in the image above. Which of the following is the most likely diagnosis in this patient? So this is our last diagnosis question of the day. A, basal cell carcinoma. B, actinic keratosis. C, pyogenic granuloma. Or D, squamous cell carcinoma. Give you guys a minute to review. The answer to this question is, it is a basal cell carcinoma. We actually just talked about this, so this is a good review. So basal cell carcinomas, the risk factors for these are going to be sun, UV exposure, fair skin, and ionizing radiation. The clinical features are going to be either skin-colored, pearly nodule, with or without the rolled borders. As we see here, that kind of pearly rolled border right there. Sometimes there's a central ulceration and local invasion. As you can kind of see, that actual BCC is a little ulcerated. The diagnosis is going to be shave, punch, or excisional biopsy, which we just kind of discussed. And then treatment, Mohs micrographic surgery. Second line would be those topicals if they are low-risk tumors only. So let's review the explanation. This patient has a slow-growing, ulcerated, pearly nodule with a rolled border on sun-exposed skin, the back of that neck there. Typical features of basal cell carcinoma. So since we know kind of what that looks like based off of our last question, we will go down to the incorrect answer choices and see why they're incorrect. B, actinic keratosis. It's a premalignant lesion which presents as a small, scaly papule or plaque with an erythematous base. So let's take a look at what that actually would look like. you're going to have this hyperkeratotic plaque-like lesion, also in a sun-exposed area, but as you see, it looks slightly different from that basal cell carcinoma that we just saw. Okay. So choice C, pyogenic granuloma. Those are vascular tumors that present as a red, beefy, friable nodule that grows rapidly over weeks to months. Those lesions can bleed with minor trauma, but are not typically ulcerated. And this is going to be what that area looks like. Bright red, vascular, kind of on this patient's lip area. Looks a little different. There's no ulceration there. And then choice D, squamous cell carcinoma. It's a much less common carcinoma and it grows much faster than basal cell carcinoma. It often arises from a precursor lesion such as actinic keratosis and typically has overlying hyperkeratosis. So this is what a squamous cell carcinoma is going to look like. Red, scaly patch with open sore and overlying hyperkeratosis, as you can kind of see surrounding that lesion on the patient's foot. Okay. So since we have reached our last question, this will be a good time to go over the study features that we talked about at the beginning of the session. So let's say you're the type of learner that does really well with quick repetition and flashcards. So if you wanted to take this image of this basal cell carcinoma, you would click on it and this would pop up. Now at the bottom, you see you can zoom in, zoom out, reset, or you see this little lightning bolt that has new, existing, or my notebook. Now we'll come back to my notebook later, but let's say we want to create a new flashcard. We would click on that, and this would pop up. As you see, it's already been labeled Dermatology, but you can label it whatever you like for your own flashcard deck. And this would be the front of the card. So we have that little picture there. You can free type whatever you like down here. What is the diagnosis? There we go. So that way you can put whatever question you like. You can bold it, format it however you would like. And then on the back of the card, say you'd like to have this chart. You'd go over, click the chart. You'd see this pop up, hit add to flashcard, and you can put it either on the front, or if you prefer to have this on the back, you can switch to the back. Either way you'd like. Down here, you can add your own tag names. Right now it already has non-melanoma skin cancer, so you can add whatever tags you like to add to be able to find it quickly when you search. Just separate them each by a comma, and then you would save it. And that's going to be saved to your flashcards, which we will view in just a second. Now, say you're the type of learner that prefers to create your own study guides, and you want to put as much information as you can stick in a Word document so that you don't forget any information to review it later. You could also click that and you will see what's known as notebook. You click that, you're going to see my notebook come up, and we've already had some little notes created in here under the FNP tab, and the first bullet point is this here. Say this was blank and you wanted to add a new note, you would just click the plus sign up here. It's going to create an untitled, say basal cell carcinoma, and you click it, left click it, and just click add content here. So now all of that's going to enter into this page. And so this is actually really good if you're the type of person to make your own study guide and you want to add any other study material notes that you may have to keep it all in one place. So if you're using multiple things and you want to make sure you don't forget anything and you don't want to have some information here and some information there, you can put all of that into your My Notebook function so it's all in one place. So we would just hit save here, and it has been saved successfully. So let's exit out of the exam so I can show you where that is on the platform. So this is going to be your UWorld FNP platform. On this left-hand side here, you would go down to flashcards, and here are some flashcards that have already been made based off of the questions that we reviewed today. So one really cool thing, if you go up to study, you can choose multiple decks. If you go through and you do dermatology, if you do respiratory, if you do cardiovascular, you can make different decks of different flashcards for you to study. For us today, since we're doing dermatology, it's already had 4 cards in it. If you go over here to the right under action and click this little arrow and hover, it'll say study now. So if you click that, the first card is going to come out. Now you can either do a single side view, and it's going to start with the front always, it's going to default to that, or you can click this and do the side to side double side view. So for this question that we did today, what is the diagnosis? Now you can click in 2 places. You can either click on this back side here, or you can hit show answer. And then everything that you stuck on the back of that flashcard is going to come up, including the paragraph that you added and the photo. Now this is the best part of the flashcard function. It's something called spaced repetition. So that's going to be the frequency in which the cards show up in your study time. So if this was super easy and you're like, oh, I recognized it, that's going to be a Tinea Capitis, you would click easy, and this card would not show up for about 4 days or more. Just, it doesn't show up that often. If you're like, yeah, I kind of knew it, but I do want to see it again a little sooner, you would just hit good. If you saw it, you couldn't figure it out at all, you're like, no, I need to see that one again. You would hit again, and that card is going to show up more frequently. So every time you go to study, you want to make sure that you put in either again, good, or easy, so that you don't see cards that are too easy too frequently, but you see the cards that are hard more frequently. That's known as spaced repetition. So that's a really good feature. Additionally, you can shuffle the decks, you can go between decks, just to get a good study rhythm going with your different cards. Okay, so since we're talking about studying, let's give another test tip. So test tip number 2 is going to be when it's time for you to start studying for your exam, whether it's 4 to 6 months out, or if you want to wait until after graduation, within that 30 to 60 day period, what is really effective and helpful is creating what's known as a calendar. So that way, not only do you have like the days to each days to your exam, your test date, but you can also put what you're going to study and when. What's really effective is if you break down the test itself either by competency. If you want to do assessment questions, diagnosis questions, you can do it that way. What's even better is if you break it down by system. So if you want to have a cardiovascular system a week, if you want to have a respiratory system week, or split them depending on how long it is between when you start studying and your test. If you do it that way, let's say the first week is cardiovascular and respiratory. That week, you will only focus on studying cardiovascular and respiratory questions. You'll do that week. At the very end, if you want to set up a test here in the UWorld FNP QBank and only select those type of questions to go through, see how you do. Whichever of those is your weakest, you would take it, add it to the last week of your calendar. You do that every single week. Whichever is your weakest, add it to the last week of your calendar. That way, you will focus on what's your weakest subjects right before the test, increasing your chances of remembering it because you saw it last, and you already know that you're good in your strongest subjects. So that's a good test, a way to remember the information on test day. So that will complete our second UWorld FNP review session. Make sure that you subscribe to the UWorld Nursing channel because we have one more FNP review session coming at the end of July, and you want to make sure that you have your notifications on so that you don't miss that review when it comes up. If you have any questions, feel free to write them in the chat below. If you liked what you saw and you're kind of interested in the product, in the description below, there's going to be a link that will take you to a free trial. Or you can also just purchase it from that link directly as well so that you can get to studying and be ready and prepared for those boards. But until next time, I'll see you.